can we start now? Sure.
Okay. Thank you. Good evening, all colleagues, and good evening, Dr. Prashant Advani, sir. This is a great occasion for us to have an expert speaker like Dr. Prashant Advani, sir, with us today. And you all know, all MQR colleagues, my colleagues at HO, my colleagues in the field, they all know that we are celebrating 20 years of chirality. MQR is house of innovation, and MQR brought these products, S-metoprolol, S-amlodipine, chirally pure molecules for first time in India, and we are celebrating 20 years. And you know that for celebrating this 20 years of chirality, we have a lot of initiatives planned in this year. And one of the initiative is again strengthening our knowledge in terms of chirality and molecules and learning from the horse's mouth. And for this, we have none other than Dr. Prashant Advani, sir. And Dr. Prashant Advani, sir, has long association with MQR in the past also. I have personally conducted a international speaker program for other division of MQR, where Dr. Prashant Advani, sir, participated as expert panelist. You had a session of XDO Arni session by Dr. Prashant Advani, sir, in the past, and it was well appreciated. The way he talks and the way he explains the things is immensely simple and lucid for everyone to understand. You have also associated with Dr. Prashant Advani, sir, in lipid webinar, where he was expert panelist during the discussion. What I like about Dr. Prashant Advani, sir, is he's very passionate about disseminating his knowledge to doctors, field force, colleagues, everybody. He's always very passionate, and he's always curious to upgrade himself, update himself in terms of knowledge. So let me have privilege to introduce Dr. Prashant Advani, sir. Sir is senior consultant clinical and preventive cardiologist at Advani Heartline and Metabolic Center, Raipur. Director, Advani Heartline and Metabolic Center, Raipur. Sir is honorary and visiting consultant at various corporate hospitals at Raipur. Sir is speaker at various national and international cardiac and cardiometabolic events and congresses. Sir has published research articles at various national and international index journals. Sir is passionate about disseminating current medical knowledge amongst medical professionals through seminars, CMEs, ad boards, and conferences. Thank you, sir, for joining today, and thank you, sir, for agreeing to share your time as well as wisdom with us today. And let me brief you all on the agenda for today. After this introduction, I'll hand over the session to Dr. Prashant Advani, sir, where he talk about basic concept about S-metoprolol and chirality. He will talk about 30-35 minutes, and last 15 minutes we'll have audience question and answer. Please paste your questions. Please put up your questions in the comment box. So after the presentation, we'll take up those questions at the end. So without further ado, let's make the most use of this session. This is a great opportunity to learn, and I'm sure that at the end of this session, we'll have many more insights and many more concepts refreshed again about the chirality. Thank you, sir. Over to you.
Thanks, Dr. Rishikesh, for the introduction, and thanks for the invite. Am I muted? Am I audible?
Audible, sir. Audible. Yes, sir, you are audible.
So good evening, everybody, and let's have a kind of an interactive thing. And I'll set certain perspective initially. Say everything we manage nowadays is to manage the hard outcomes, heart attacks, sudden deaths, and MIs and strokes and limb events, kidney events. We have to protect organs. Can you see my screen now?
Yes, sir. Your screen is there.
Yes, sir.
Yeah. Oh. Enable editing.
We can see.
Yes, sir. So please make it full screen.
Yeah. Okay. Yeah. Now from here, and then from beginning. Yes,
we can see.
So Chirality S-metoprolol is the title, but then I'll discuss so many things so that you understand better all this thing. And beta blockers in modern medicine I appreciate the line modern medicine and unveiling the power of S-metoprolol, of course. So I'll try to prove my point here. So as I was alluding to, we are managing a disease to prevent this organ. You are seeing live beating heart, and this organ is at a peril. And in India, we are witnessing, at least as a supercovalent in my area, I see in early 20s and late 20s, 30s, the people are coming directly with heart events, right? They have an MI, they have revascularization, hospitalization, acute coronary syndrome, acute ischemic valve dysfunction happening very rampantly. So it's not that it's not been happening in the past, it's been happening बहुत time से हो रहा है. But there's certain more things have contributed to it. Pollution, microplastic, adulteration in the food, rapid urbanization, gizmos and gizmation, physical inactivity, that has contributed to the previous risk factors, out of which I think hypertension is a very robust one. So I have to first tell you about what's happening around us and why we want to market a product or sell a product or want to have our patients have this product in a righteous way through the SCPs that you are going to meet. The physiological understanding of cardiometabolic disease is a must, which I'm going to say, whatever, you cannot understand otherwise the molecule. Then, of course, how beta blockers have in Indian setting, in India, how they are important. Metoprolol is a decades old, more than 50 years as a molecule, how it still holds a relevance and how I can make, and how I have to compare amongst the titans, metoprolol, bisoprolol, carvedilol, these are all titans in their respective realms. But how metoprolol compares with them, how you have to dig out the fineness and the nitty-gritties between the titans. In reality, how important is a concept, it's a big research and big thing, but how you can make a molecule even more refined or more better or more efficacious and without flip sides. S-metoprolol, that is S-metoprolol, and how best we use and what are the points that I can say to my SCP I'm going to meet, be it a general practitioner or a physician or a cardiac physician or interventional cardiologist or a nephrologist or any cardiometabolic internist, how I'm going to tell what are the salient points. If I don't understand the basic pathophysiology, I can't understand. I can just mug up and rot learn and just speak whatever is written on the folder. And you know that how busy we are and very difficult to listen to your entire story. So you have to be well versed with this thing. As I was alluding to, hypertension is the leading risk factor, more so in Indian setting. And it causes so much of sheer stress on the vessel wall. And from other modifiable, non-modifiable risk factor. And in spite of we know this thing, we don't manage it well. So these three big luminaries in World War times died of hypertension and also in the current realm. So this is a picture, and I said this is in spite of the fact that we know how obnoxious, how vicious it is for our vascular system, and but we don't do about it in spite of knowing it so much, so many webinars, so much access to the information. Yet something is amiss somewhere, not only in hypertension, all chronic NCD management, non-communicable disease management, and hypertension is part of it. Are we different in India? This is my slide where I say, are we different in India? All the guidelines across Atlantic are American, European. They consider us South Asians. They don't say Indians because it could be raciality attached to it. So Indians are a vulnerable population, high risk population. So in India, if you are managing lipids, you are managing hypertension, you are managing diabetes, we are at a high risk. Or at least moderate, no low risk in Indian setting. So we are elite panel in this room, 10, 12 people. We all are. It could be your field force. You are in moderate to high risk for every such thing. Kaunsi risk? Major adverse cardiovascular events, sudden death. I was all well yesterday. I died, and you also must be witnessing in your parlance, right? Your many colleagues, just suddenly give way. They were all well. Or there are lab reports coming abnormal, some dyslipidemia, some casual blood pressure reading is abnormal, some casual lipid abnormalities, and you keep hearing about family history and the kind of exposure that we have, irregular or not so predictable dietary patterns and timings and sleeping, and the exposure to pollution, pan-Indian, you go wherever. So that generates so much of risk factors which are tangible, which we know, and intangible, which we don't know. And this is what about India? Indian hypertensives are 88% are uncontrolled, and every 2.5, not third person is hypertensive nowadays. So we have a genetics we have been bequeathed with. These are all my slides to make understand. हमको genetics तो मिल गया है, तो हम Indians हैं, South Asians हैं, लेकिन हमारी lifestyle भी उस genetics की gun को trigger को pull कर रही है. So you genetics load the gun and lifestyle pulls the trigger. And what is so specific about us that we are not so obese? I was in US. They're kind of a rhino-like looking population. They are so fat, but yet the average ages of major heart events is upwards of 50, and here in India is upwards of 30. So we are thin fat, and we have central obesity. This dysfunctional electricity runs havoc. We know that, and this causes all metabolic syndrome. We always knew this thing, and part of which is sympathetic activation over sympathetic overactivation. I'm not needing sympathetic drive, but my system is producing so much of norepinephrine, epinephrine in the slide. It is around omentum, it is around liver, it's around perinephric area, over arteries, over pericardium, which you can't see from outside. So this guy's BMI is only 24, but it's very fat for his system. And this generates so much of inflammation. We call it vascular inflammation, CV inflammation, which is the root cause, and it generates so much of insulin resistance. और जो endothelium हमारा होता है, the endothelium that we have, the biggest organ of the body and biggest endocrine organ of the body, which is otherwise वो growth नहीं होने देता, regulation नहीं होने देता, inflammation को रोकता है. But the kind of lifestyle we have, the kind of genetics we have, the epigenetics we have, that actually creates a phenotype. वो जो बेचारी endothelium was very functional, gradually, subtly become opposite. The seesaw balance towards it being constrictive, growth promoting, pro-thrombotic, pro-inflammation, and pro-oxidative. So half of the mankind in India dies of inflammation or atherothrombosis. And we know that. And I'll come back to it when I end my talk after explaining everything. And we generate so much of, because of lifestyle, kind of a sympathetic tone, abnormal SNS, norepinephrine, epinephrine, catecholamines. And you and me measure casually, they are in micromoles per liter. They're already high from the subtle levels, which we don't realize from outside. And that दीमक की तरह वो हमारे एंडोथीलियम को डिसफंक्शनल बना रहा है और insulin resistance को थोड़ा थोड़ा बढ़ा रहा है, which we cannot see from outside. I'm inquisitively measuring in my patient and I see the endothelial function assessments. तो उसके साथ साथ इसका जो दूसरा साथी है, normal RAS activation, so angiotensin 2. So RAS, SNS, two terrorists coming together, diabolical alliance in Indian setting, leads to consequentially sodium water retention, higher vascular tone, and endothelium. Endothelium does all its good job. Nitric oxide endothelium के लिए एक जड़ी बूटी है. It's a panacea which actually is not able to match up because of overt and covert and hidden and expressed lifestyle factors. And our vessel, our age is now our vessel's age, and our vessels are on fire. And this is, we know that how atherothrombosis is, and you sell a product called Elaxim, and this is Orvelix, and this is how it actually, where a thrombus is dissolved and gives a life-saving thing. If you have a 20% plaque rupture and there's a de novo thrombus in a young guy who is just 23 and suddenly comes with these events because of constellation of cardiovascular risk factor. So thoda sa blood pressure abnormality, vasomer, thoda sa endothelial dysfunction, inflammatory oxidative state, reactive oxygen species, dysglycemia, dyslipidemia, subtle. And you have an event in background of your bad genetics. So ये सब का driving force क्या था? जो ये हम शुरुआत होती है, minor atherosclerosis, minor ischemias, minor all these events and minor loss of functions and sudden plaque ruptures. There's a plaque sitting somewhere in a coronaries, which otherwise should have been very smoothly flowing, dilatory, anti-thrombotic, anti-inflammatory, antioxidant. I told you in the seesaw balance, it becomes certainly like this. Probably in me and you may be happening. So it's waiting for a trigger event to generate a turning point, a D-Day. We are here through these molecules, including metoprolol, to prevent that D-Day. And we have to phenotype our patient. This continuum of heart disease, the driving force is heightened SNS activity, heightened RAS activity. When I say SNS, sympathetic nervous system, I say angiotensin, norepinephrine, epinephrine, catecholamines, which you cannot measure. You can measure by a blood test, it's not required, but we Indians are having all these things. And that leads to, that's coming, and that actually generates hypertension comes after it. That these are the driving forces. And when you higher SNS, we know that हम बचपन में भी पढ़ते थे स्कूल में कि higher sympathetic, if high sympathetic आपका heart rate ज़्यादा जाता. You have elevated heart rate. So we Indians have a phenotype जहाँ हमारी heart rate वैसे ही ज़्यादा रहता है, resting heart rate. And we don't do aerobics too, which actually increases the उसका opposite क्या होता है, vagal tone बढ़ाओ, parasympathetic बढ़ाओ, sympathetic बढ़ा हुआ है, parasympathetic को बढ़ाना है. But we don't do aerobics, we don't make our muscles, and we are generally sarcopenic as compared to the Caucasian counterparts. So we have this kind of a syndrome where elevated heart rate also accentuates the problem that we have already been bequeathed with through our genetics. So subtle atherosclerosis, then it progresses faster. When the turning point come, when your plaque rupture, it could be just 20%, 30%, 40%, it ruptures and thrombus formation. So these young MIs have more of a thrombus rather than progressive atherosclerotic plaques. So, and then you have organ damages. If you survive that heart attack, then your heart reserves have gone down. It might land up into the coronary plaque rupture, and MI gives fibrosis and not so well managed, and you end up in a very grotesquely leaking myocardium, heart failures, and also the heart renal axis. The renal continuum is also there. Microalbuminuria, then advanced nephropathy and end-stage nephropathy, and this go hand in. And this all is accentuated by what I started with. The genetics, epigenetics, lifestyle, or hamara dysfunctional adiposity. And then the generates insulin resistance. So much of vascular inflammation, oxidation, and cardiovascular system and kidneys are going hand in hand, they are going together. Nowadays, we are working as a cardiac fellow also and work on cardio-renal axis metabolic preservation. And I'm fellow of American Art where they say cardiovascular kidney metabolic continuum. And this presidential advisory from AHA came in 23 October 23, and this is like you cannot compartmentalize medicine. आप किसी से भी मिलने जाते हैं, आपको ये बताना है कि ओवरऑल सिस्टम को बचाना है हमें. So all of us are stage 2 of kind of CKM syndrome, cardiovascular kidney metabolic syndrome. I'm sure Dr. Rishikesh must have heard of it. And the patient come as stage 4. They already have MI and heart failures and atrial fibrillation and previous strokes and revascularization. And I work at papers in stage 3, subclinical. So it could be me and you or somebody of my age in upwards of 35, maybe having subclinical ASCVD, subclinical heart failure. I can just pick up, oh, you are all good from outside. आपको लगता है आपका BP और सब कुछ, you have controlled it. But how your organ function, which are subtle, hidden, and how this beta blocking properties in India can reverse or progress the relentless, inexorable, upwards cascading progression. Or anytime ACS can pump in. So you are on a chronic ASCVD timeline in which ACS as bombard in or gate crash anytime. So I'm here to prevent your ACS and sudden death. And Indian facts, I've already told, people are not aware. Hypertension is silent killer. Many people are not, even if they're aware, not treated well. Also, it's also physicians' inertia is also a problem. So आप जिनसे मिलने जाते हैं, आप समझाने की भी कोशिश करते हैं. You try to make your SCP understand. At times, pharma person knows so much. And I love a person who comes to me and gives me some fact through his pamphlets or through information and apprises me of something new which I didn't know. And I very appreciate, I'll give him a candy. Oh, so learning never stops. It's a continuum and you and me can learn from each other. At times, are not so well-managed hypertension. Everything is individualization, era of precision medicine. You have to choose for your patient. So SCP को पता होना चाहिए कि वो उस आदमी के लिए कौन सा एंटी हाइपरटेंसिव एजेंट लेना है. अगर आपको X ड्रग से कंट्रोल करना तो आपने Y ड्रग से कंट्रोल कर लिया, that also makes a difference. And not only hypertension, you have to see the other structural functional comorbidities. Blood pressure के अलावा sugars, lipids, adiposity, residual inflammatory risk, thrombotic risk. So we have to be a good internist in order to assess the system. This is called chronic cardiometabolic hepatic continuum. I'm managing entire body, entire system, entire endothelium. Endothelium is in all the parts. I'm not managing a tubular thing and I'm only for blood pressure, I'm only for the lesion. Atherosclerosis is a focal disease. Right? It's a systemic disease, but stenosis is the focal representation. And you have to manage entire atherothrombotic process. So going back to Indian setting, we are adrenergic. We are designed in such a way, wired in such a way, थोड़ा सा physical inactivity, थोड़ा odors of fat, थोड़ा सा डाइटरी पैटर्न, थोड़ा सर्केडियन रिदम बिगड़ा और हमारा जैसे ही हाइपरडाइड्रेनर्जिक है और थोड़ा सा एंजियोटेंसिन 2 के साथ ये नॉर एपिनेफ्रिन सर्कुलेशन में आ जाता है. And that creates a syndrome of cardiovascular kidney metabolic continuum, which I've already read. We call it dysmetabolic syndrome. उसके अलावा जो हमारा ब्लड प्रेशर होता है वो रात में डिप नहीं करता, हमको वैसे रहता है. So our blood pressure don't dip. Or if we dip our blood pressure, we don't dip our heart rate in the night time. So if you don't dip your heart rate in the night time, the system goes haywire, it becomes dysfunctional, it makes more atherosclerosis. तो एथेरोस्क्लेरोसिस के ऊपर भी एक कैप होती है कि वो उसको ढक के रखता है. एथेरोस्क्लेरोसिस हो भी गया तो प्लाक के ऊपर ऐसा दीवार होता है कि उसको फटने ना दे. इट डजंट लेट इट रप्चर बिकॉज रप्चर इज समथिंग व्हिच किल्स यू और चेंजेस योर लाइफ विस्टास. सो इट मेक्स इट थिक थिक कैप होना चाहिए. पर इस तरीके की लाइफस्टाइल, हाई हार्ट रेट, हाई एडिनर्जिक स्टेट, नॉट सो प्रॉपरली मैनेज्ड, वो उसकी थिक कैप को थिन कर देता है. और एक कोई टाइम वो आपने शादी में डांस कर लिया, कहीं दौड़ गए, हैवी खा लिया, एक बहुत ह्यूमिडिटी हो गई, प्रोलॉन्ग फास्टिंग कर ली, अनड्यू स्ट्रेस आ गया और वो फट गया. एंड देन यू हैड इट. एंड वी कीप ऑन हियरिंग दैट थिंग. So we have constellation of cardiovascular risk factors, the kind of phenotype that we have. और ये ब्रेन भी हैरान हो जाता है कि मैं इसको रेगुलेट नहीं कर पा रहा. आइडियली सिंपैथेटिक नर्वस सिस्टम, ऑटोनॉमिक नर्वस सिस्टम शुड बी रेगुलेटेड बाय हेयर. But Indian hypertension is coming from central adiposity. And from the genotype, phenotype, it's not bridled. उसके ऊपर लगाम नहीं लगाया है. So we have to be careful. So, and then this Indian data, we have average height, including doctors. Is on doctors data कि doctors की heart rate 84-85 है. अपनी क्लिनिक में बैठे हैं 3 घंटे से और heart rate उसका 84-85 है. तो आप किसी SCP से मिलने जाएं तो of course with all after making a repo पूछो आपकी सर heart rate कितनी रहती है. तो सर ही हैरान हो जाएंगे कि ये बच्चा मुझे बता रहा है. And you have to prevent. So they have to be wary of this thing. और ये मेरी स्लाइड है जहाँ मैं बताता हूँ कि we have high stress, including me. Competitive work life, renin activity high, sympathetic activity high, norepinephrine in the circulation high, और vessel compliance भी high. मतलब हम तो young हैं. So LVH और आप जो field force में जो मेरे officers हैं वो सब almost young हैं. Young means under 55. Of course हमारे यहाँ youth अब नीचे जाता जा रहा है और ये सब हमारे LA strains और ये होते हैं. Simply हमारा norepinephrine high है. Now finally, in this entire continuum, the role of beta blockers have been recognized by ESC, ESH guidelines कि these Asians, पहले उन्होंने बीटा ब्लॉकर को हटा लिया था, but then now they realize इंडिया में जो चीज ही अलग है. We are not able to fathom कि यहाँ पे बीटा ब्लॉकर्स सबसे पहले they could be, पहले ये था कि आपको हार्ट डिजीज है, हार्ट फेलियर है, MI आया है, PC आया है, तो ही आपको देना है और मतलब कॉम्प्लिकेटेड हाइपरटेंशन में देना है. But I said in initial, I told you a story. Borderline hypertension, borderline dyslipidemia, and borderline at lifestyle factors can kill you. So why wait for an event to happen? You have to prevent him. The prevention is the best mode of treatment. So in this entire continuum, जिसमें sudden death भी हो सकती है, beta blocker has a major role to play because of the things that I have. And I also come back to these things because it's very difficult to understand in one setting. Beta blockers have a role to play in this entire continuum of I am here to prevent the death. You sell a product to prevent a death. HCP is here to prevent a sudden cardiac death. The most prevalent death in India is sudden cardiac death. And sudden cardiac death means I was all good. 1 घंटे में मैं मर गया. और mostly the people die in 10 minutes. And cases of beta blocker in hypertension before 23 was heart failure, angina, post-MI, atrial fibrillation. These were सेनाई को नन इंडिकेशन. ये आज भी है कि आप किसी को हार्ट फेलियर है, एंजीना है, उसको देना ही है. बीटा ब्लॉकर नहीं देना क्रिमिनल है, अनएथिकल है. लेकिन अब व्हाट अबाउट अ पर्सन यू एंड मी और जिसको जस्ट ब्लड प्रेशर 142/86 है, उसको देना है या नहीं? उसको आज तक कुछ नहीं हुआ. Here, so you have uncomplicated hypertension. You have so many such phenotypes I told you. Your high stress, your competitive work life, your high renin activity. You are Indian and your BMI is 26. And if you have borderline stage 1 hypertension and other risk factors, you have to have beta blocker. The modern generation chemically engineered beta blocker, right? Like S-metoprolol. Or say again, of course, the modern generation B. So now I'll tell you how these are different. Nabil, how they are important in current generations, the chronic NCD management in OPDs. So I again come back to my point, why beta blockers were removed as primary agents in uncomplicated hypertension. Then amyled also then to yes, the beta blockers now may likely remain in consideration. This is the guidelines, and then the guidelines become your inquisitive concept is fathered by somebody. So now we know, we always had this hierarchical management, low dose, 2 drug combination, RAS inhibition, ACE, ARB, CCBO diuretic, then maximum combination, and then this is very simple, or MRAs for resistant. But now beta blocker can come in any time. So the ESC is saying को जाके एससीपी को बताना है कि सर अब गया वो जमाना कि आपको पहले एमआई और इस सब का होने का वेट करना है. You can just give to the one who is having high resting height rate, central adiposity, and two other risk factors like dyslipidemia or dysglycemia, HbA1c just 6.8, and stage 1 hypertension for risk reduction. So beta blockers can be prescribed in any time in the continuum for Indians. It's for South Asians. And now they finally recognize, because I just told you why beta blockers, we deserve beta blockers because of the phenotype that we have been born with. So we have genetics, loaded guns, we have lifestyle, the trigger, and we have this environment, very polluted, adulterated, full of inorganic solvents and microplastics, and that generates inflammation too. And then we don't do physical work and we never make our muscles. Include we, I say we because I'm included. That's how we need them. रिस्क एवर्स, तो हमारे रिस्क फैक्टर्स को हम तो नहीं ठीक कर रहे, एक ड्रग हमको बचा रहा है हमारी रिस्क फैक्टर्स की. So that's where I think there's a consideration. It's not that only beta blockers, you have to see other things also. Your RAS inhibition, your MRA deservingness, your SGLT2 inhibitors, your proper diabetes management, your proper statinize, your proper other things. So you have to, it's a holistic thing. It's all cardio, renal, kidney, metabolic continuum. So beta blocker are the first, it could be the first line for many of my patients. If I see 60 patients, so probably 40 of them may be deserving them. So it was not up till before 2024 when the guidelines have acknowledged this fact. But I was practicing already, even if the guideline was not acknowledging. So modern generation beta blockers or pure beta blockers are very, very predictable beta blockers like S-metoprolol will be the case. So beta blockers have strong evidence, have can be given to stage 1 hypertension. Everything is risk dependent. On my stage 1 hypertension also not benign. It's also not with low risk. I started with saying India में low risk नहीं होता. India is moderate से ऊपर से ही चालू होता है. और generally मेरे पास जो patient आते हैं, they come in the last. I drain entire 1000 kilometer, 50, 60, 70 packs in a day. Everybody is high risk. And most of them are under 40. Extremely high risk for the major adverse cardiovascular events. Cerebrovascular events also. Due to non-selectivity in first and second generation, बीटा ब्लॉकर्स को ज्यादा गाली पड़ी थी क्योंकि एटिनोलॉल जैसे बीटा ब्लॉकर्स थे, नॉन सेलेक्टिव बीटा ब्लॉकर्स थे, सारी ट्रायल्स में वो यूज हुए. पर मॉडर्न जनरेशन हैड दे यूज देन एस-मेटोप्रोलोल को तब यूज करते 95 में, 98 की किसी ट्रायल में या अर्ली 2000 में, तो उनको पता चलता कि ये इतना द आउटकम्स वर नॉट एज बैड. So all the ignominy that was brought from beta blockers actually brought from not so competent, not so deserving beta blockers used in the trial like atenolol, propranolol, nexendrolol, or all these non-selective beta blockers. Newer generation, highly selective, like metoprolol, bisoprolol, and nebivolol are different. So this is a heterogeneous class. In the same class, we and me different. So doctors, say cardiologists is a heterogeneous class. My understanding of subject and my colleagues' understanding of subject is different. So you cannot equate me. So my line of treatment is different. His line of treatment is different. Maybe he's equally qualified in terms of papers. So similarly, all two beta blockers are not same, and they are different in terms of their mortality or hard outcomes removing profile and side effect profile. So this is where you have to be wary of the fact. So guidelines now say you can be writing in even in uncomplicated. So what about heart failure? Their first approval came in after Merit HF and Copernicus after heart failure in late 1919. When I was in MBBS, beta blockers were contraindicated in heart failure. Now this is a big paradigm shift. जैसे हम जब डायबिटीज पढ़ते थे कि ग्लाइकोसूरिया नहीं होना चाहिए, यूरिन में शुगर नहीं जाना चाहिए. Probably Dr. Rishikesh also was in that time. And now we create glycosuria. We block SGLT2 inhibitors. We create glycosuria. Urine sugar हमेशा 4+ आएगा और उसी से सारा फायदा हो रहा है. So such a paradigm shift. So beta blockers in heart failure is a paradigm shift. What they were indicated ever since the modern medicine, then in the allopathic medicine for after 98. And this heart failure, they become the foundational pillar. And you know that we have RAS inhibition, we have beta blockers, and RAS inhibition, we talk of angiotensin receptor nebulizer inhibition, like you have X-Duo as a wonderful product, MRAs and SGLT2. These are found, and then you have to phenotype and write the other ancillary drugs. And beta blocker landmark trials, ये आपको जानना जरूरी नहीं है, पर The field force doesn't have to know it, but the merit HF, a trial with maximum number inclusion, high risk patient, and maximum mortality, cardiovascular death reduction, and arrhythmia protection from metoprolol succinate. Till date, it is the numero in bad the LV. बहुत बुरा पेशेंट है, बार बार हॉस्पिटलाइज हुआ है, बहुत सारे प्रोसीजर हो रखे हैं, सिवियर हार्ट फेलियर है, सिवियरली डायलेटेड एलवी है, हाई एक्सेंट्रिसिटी इंडेक्स है, बहुत सारा माइट्रल रिगर्जिटेशन है, ट्रांसप्लांट के पास ऐसे पेशेंट मेटोप्रोलॉल सक्सिनेट से ज्यादा सर्वाइव करते एज कंपेयर टू बिसोप्रोलॉल एंड कार्बिडिलॉल. और दिस इज अ practical thing. So but somebody who receives carbidiolol or Lolol is equally fine because you have to write beta blockers and chronic HF, the depressed ejection, heart failure with depressed ejection fraction. मैंने अभी आपको पिक्चर दिखाया जिसमें हम लोग देखते हैं कि हार्ट में कौन सा वाला हार्ट फेलियर है. तो ये जो बीच वाला है, it's a central one. It's a dilated, remodeled, unshapely, grotesquely looking LV, which is pumping just at 35, 30%, 25%, not a robust pumping like this. So इसमें beta blocker तो देना ही है, नहीं देना it's criminal, right? Here तो it is a situation. But again, I started with saying, what about a chalta firta guy or a normal looking quasi perfect guy who thinks he's all good, and does he deserve beta blockers for various situations, including metoprolol and then S-metoprolol without the side effects? So this is where the trials for beta blockers in heart failure, these all are big landmark trials, and medicine has changed ever since. And these are the recommendation. And metoprolol most commonly used. So in worldwide, 70% पेशेंट जो है फ्रेफ में हार्ट फेलियर, रिड्यूस इजेक्शन फ्रैक्शन, जिनके पंपिंग हार्ट की पंपिंग 40% से कम है, below 40% if they are on metoprolol succinate, not the tartrate one, metoprolol succinate. So this is a usual established fact. There's so many prospective studies comparing it with other beta blockers. So if you compare with bisoprolol or carbidiolol, so of course you are comparing between titans. Two superstars are being compared. So there are subtle differences. But in an Indian setting, if you say Indian setting, so if you compare metoprolol, because its propensity to the receptor, and then it's compared to the bisoprolol. Of course, it also acts on a racemic beta blocker, metoprolol, which is mix of both S and R. I'll tell you subsequently. And maybe affecting the beta 2 also at some time. And in heart failure, metoprolol, the slide has come now, as I said it already. It works for sudden cardiac death and all-cause mortality. So आप हार्ट किसी की डेथ हो गई तो वो हार्ट के कॉज की वजह से हुई या वैसे ही किसी बात से मर गया, दोनों कम हो जाते हैं if in heart failure, if you write metoprolol succinate in conjunction with other pillars of heart, foundational pillars. In merit HF outcomes, metoprolol has shown a heart failure mortality to the tune of 50%. No other in the bisoprolol trials and carbidiolol trials had been replicated. Of course, they were also the morbidity and mortality was lesser. If you compare with other congeners and regarding ignominy, other allegation जो beta blockers पे लगता है, अरे यार ये long run में मैं दूंगा तो मेरे को diabetes हो जाएगी, मेरा lipid बिगड़ जाएगा. So if I have a concern, if I give on a longer run in uncomplicated hypertension, am I going to disturb my lipid profile or my homeostasis? So succinate already compared to bisoprolol. Bisoprolol was considered highly beta selective and very safe, but in this aspect, they said bisoprolol, metoprolol ने तो कुछ किया ही नहीं. It was जैसे Supreme Court ने बरी कर दिया उसको. And bisoprolol has some G elevation, so it is all on the same platter. So if I make changes in my racemic beta metoprolol, तो ये पहले से इतना अच्छा है, तो can I still make it better? I'm going to come to that thing. And this is where they with other bisoprolol and then combination with bisoprolol metoprolol. So they are safe, efficacious, both of them. Some marginal betterment in these head-on comparisons or a sustained and control with combination over the time. If they have compared it 4 months, and that compared that's both systolic, diastolic blood pressure falls, and this is and also in conjunction with telmisartan. So these marginal studies may not be reckoned as in my opinion. If I say, of course, metoprolol succinate is robust systolic blood pressure reducer amongst the class. It's a very robust one. But then in which indication it is improved? मैंने अभी बताया uncomplicated hypertension भी एक indication बन गया. जो सबसे बड़ा इंडिकेशन है. And then heart failure, MI, angina, heart disease, वो तो कम लोगों को, but then we are here to protect after controlling hypertension, even in stage 1 in a better way. So then you don't reach that state. So when finally come to, we have to compare bisoprolol and S-metoprolol. Now, when I made it pure, now it is good. I'll tell you how I made it pure. So how I compare. So indication in cardiovascular disease, which is an established indication for beta blockers. आप क्लिनिक में जाएंगे, आपको बताना है कि हार्ट फेलियर में तो ये होता ही है. यू डोंट हैव टू टेल दिस गाय मस्ट दिस एक्सपेक्टेड टू नो ऑल दिस थिंग्स. एंड इसका सबसे बड़ा एडवांटेज है मेटोप्रोल सक्सिनेट का कि ये सडन डेथ का जो क्वालिटी ऑफ लाइफ दोनों इक्वली इंप्रूव करेंगे, लॉन्जेविटी भी. बट द सडन डेथ जो बीच में होता है वो अगर बैट द एलवी बेटर विद मेटोप्रोल सक्सिनेट. आई शिफ्ट माय पेशेंट फ्रॉम दैट टू दिस. समबडी हैड a DC shock or in hospital arrhythmias or some complex CVT, तो मुझे पता चल जाता है कि इसका arrhythmia हो सकता है, कभी मर सकता है, तो उसको bisoprolol succinate पे शिफ्ट करो. Efficacy in chronic heart failure patient, yes, so both, and this decreases all cause mortality. तो किसी भी वजह से आप heart failure में हैं और किसी और वजह से भी डेथ होती है, तो वो भी all cause mortality means death outside cardiovascular death, and that can also be lesser in metoprolol succinate as compared to bisoprolol. If you are digging between two titans, you have to see the finer differences. और ये renally चला जाता है 50% bisoprolol और hepatic. If you have renal dysfunction, you have to think. But you have advanced renal dysfunction, eGFR सिर्फ 16 ml है, 14 ml है, अभी आप क्या यूज करो? बीटा ब्लॉकर तो देना ही है. किडनी के पेशेंट्स भी, इवन द एंड स्टेज किडनी डिजीज पेशेंट, अ वेरी बैड किडनी पेशेंट डाई ऑफ हार्ट इवेंट्स. Already there's atherosclerosis, already there's prior events, already there's smoldering inflammation, progression of atherosclerosis. तो किडनी डिस्फंक्शन होने से वो एक्सिलरेटेड हो जाता है, बहुत फास्ट हो जाता है, आर्टरीज स्टिफ हो जाती है. तो इफ आई पुट बीटा ब्लॉकर, तो आई कैन एटलीस्ट रिड्यूस द पेस, और relentless downhill progression can be blunted or ameliorated. So there I need a drug which kidney पे easy हो. तो फिर वो मेटोप्रोलॉल पे आता है, और मैंने उसको S-metoprolol प्योर कर दिया, तो that's even better. So these are the pluses of metoprolol as compared to the next best bisoprolol. And then so many trials to its credit, SMART, HF, SMART, Dimension, SMASH. This is in the end, these are prospective trials just to see, मेरा सब सही तो कर रहा हूँ? So probably yes. Now comes the indication list. Apart from uncomplicated hypertension, as I started by saying, we have constellation of cardiovascular risk factors which are borderline, and even if we are stage 1 hypertensive, we deserve a beta blocker. Don't have to wait for MI, anginas, ASC, distress EKG positive, coronary artery calcium positive, coronary angiogram में plaque आएगा तब मैं लिखूंगा. No. So you have to prevent that continuum, which starts from a very thin fibro streak, and it can be horrible could be a CTO 100% block, or in any time a plaque rupture, an ACS, or sudden death can ensue. So angina, arrhythmias, every such subset or phenotype or characteristic, metoprolol succinate is in. But bisoprolol is amiss in arrhythmias. Membrane stabilization. If you have a bad heart, आपका electrical remodeling होता है. Heart irregular होना चाहता है. Heart can go into any time into a sudden life-threatening arrhythmias. वहाँ पे membranes को stable करना, वो resistant रहे, वो electrical activity से नाराज ना हो, परेशान ना हो. There you need a membrane stabilizing beta blocker, and metoprolol is one. ये हमारी pharmacology में तब से था. And carbidiol also has a good anti-hypertensive effect, very powerful, but no we don't use an anti-anginal. Anti-anginal means I have a fixed block, but अब मेरे को कभी MI नहीं हुआ, and when I block, मैं थोड़ा चलता हूँ तो मुझे heaviness होता है, मैं रुकता हूँ तो ठीक हो जाता है. This is a typical stable ischemic heart disease. अब कुछ भी हार्ट डिजीज में स्टेबल नहीं होता, एथेरोस्क्लेरोसिस भी स्टेबल नहीं होता, आगे हो रहा है पीछे हो रहा है, या हार्ट फेलियर भी स्टेबल नहीं होता. तो अब ये स्टेबल वर्ड हटता जा रहा है. वी से क्रोनिक कोरोनरी सिंड्रोम एंड क्रोनिक हार्ट फेलियर. क्रोनिक एथेरोस्क्लेरोसिस है, तो वो क्रोनिक कोरोनरी सिंड्रोम में स्टेबल इस्केमिक हार्ट स्टेबल नहीं है, क्या वो सब ठीक हो गया? क्योंकि अगर वो रिपेयर भी हो रहा है, ठीक हो रहा है, प्लाक ऑर्गेनाइज भी हो रहा है, इंट्रा प्लाक इन्फ्लेमेशन कम हो रहा है, प्लाक के अंदर से लिपिड कोर जा रहा है, तब भी वो मूव हो रहा है फॉर बेटर. और यहाँ वो वर्स हो रहा है कि थिक कैप थिन कैप हो रही है, इंट्रा प्लाक इन्फ्लेमेशन बढ़ रहा है, एंड स्मूथ मसल्स कम हो रही है इंट्रा प्लाक, तब भी वो प्रोग्रेस कर रहा है. तो इट्स वर्सनिंग. सो वर्सनिंग और बिकमिंग बेटर, बट इट्स नेवर स्टेबल. सो वी कॉल इट क्रोनिक कोरोनरी सिंड्रोम. तो उसमें सबसे पहला ड्रग आता है मेटोप्रोलॉल सक्सिनेट. And post-MI, MI, CAD, heart failures, all are equal, all are indicated. And this, I just told you about heart failure. So this is beta blockers realm. But what about a larger swaths of patient, the chunks of patient? They are roaming on the streets with borderline hypertension and risk factor. This category, I told you how they deserve metoprolol right at the beginning to control. So I'm now coming to chirality. So when I know that my patient deserve metoprolol succinate, now, but still I have a concern, racemic metoprolol. What is racemic metoprolol? So metoprolol, ROS, so this is the carbon atom, and there are 4 group hydroxyl, they are acetate, they are attached to it. अब मैं इसको जैसे mirror से if I keep it in front of a so I keep myself on the mirror, my left become right, my right become left, and I can just superimpose with that. मैं उसको जाके चिपकूंगा तो वापस एक बन जाऊँ. But here I have a mirror image, but I cannot superimpose. So these are attached in such a way they're not superimposable, though they are a mirror image. So they are isomer and also enantiomer, or some people pronounce it enantiomer. So it's enantiomer, and they have different effects. So their ligand, they're attached to their substrate, their receptor, their ligand in a different way. And general metoprolol, say Metexil, or say I shouldn't be naming brands, so there's so many of them, have at least 50% both, and they have racemic mixture. So ek racem ye hai, they're racemic, they're both and probably in equal quantity. But what I do now, they are not superimposable, so it doesn't become a one molecule back again. Likewise here, you have handedness, left hand and right hand could be a mirror image. And just I can't, but I cannot superimpose. I cannot superimpose. A bottle in a mirror can be superimposed, right? So it becomes one. But here I can't. So these are basically different entities. The same from same carbon atom, there are 4 groups attached, and they behave differently. So they are not superimposable, and they are asymmetric. Their handedness is different. So they are chiral molecules, and they're chiral central in that molecule. This is a carbon atom, is a chiral central, and these have your. So this is all hardcore engineering. I have to only tell my SCP, chemical engineering, the chemical esoteric things. What about why I have to know R and or S or something? Because this guy, in the past, we have learned a thalidomide thing. We know that how teratogenic it is, but it's an enantiomer is not. It's sedative. It's simple. It doesn't cause teratogenesis. Just here and there. I remove the impurity. इसका R वाला हटा दिया. इसका S ज़्यादा खराब था. उसका R ज़्यादा. And you have removed it, and it became all stable. Similarly, in my metoprolol's case, मेरा S enantiomer अपने receptor से बहुत tight जाके चिपकता है. Predictive काम करता है. No nonsense बातें करता है. It doesn't act on other beta ones spread around, and doesn't have binding and no corollary effect. So I don't disturb lipids, I don't disturb sugars, I don't do anything. I do my job. I go on beta 1 receptor on the heart, and I membrane stabilize. I prevent anginal events, and I do my job. I decrease circulating norepinephrine का action को होने नहीं देता मैं heart पे, because of the Indians have so much of circulating norepinephrine, epinephrine, SNS activity. I told in beginning. So I bind very predictably. I have a good predictable pharmacokinetic and pharmacodynamic profile. Or I have case studies with this thalidomide. I just told you, ethambutol, good temperature. If we make a isomer, the isomer, the enantiomer enantiomer is an isomer, but not all isomers are enantiomer, because it's a mirror image which is not superimposable. Other does blindness, penicillamine, aspergine. So just twist and I remove, and then the ligand binding and the cascading downstream cellular reprogramming effects are different. So when I know in my S-metoprolol, there's a racemate, the mixture of both. So I have a common place में किसी दुकान पे गया metoprolol दो, उसने कुछ दे दिया, तो वो ये आया, उसमें दोनों है, mix है. But I know this guy S works better. It doesn't do anything. It's a very potent one, very safe, prolonged effect, and therapeutic predictable. I want to remove this. I want it pure. So thanks to the industry like your company, Amcure, has removed this impurity, and we have analogy in other things as amlodipine, negligible pedal edema. So by thinking that way, the impurity is the other accompaniment, which is not pharmacodynamic effects are unpredictable, I remove this thing. And similarly with ondansetron, when I write for my vomiting patients, I worry about QT prolongation. When it's R on, in this case, no S, it's R ondansetron, no QT prolongation. So our racemically pure chiral counterparts have better efficacy in that solution. So S-metoprolol, chirally pure, sir, we call it chiral switch. So मैंने R से S पे switch कर दिया. So I removed almost everything. So it's 95% S or 100% S. So it's from racemate mixture of S and R, it made pure S, pure metoprolol, which I know works therapeutically better and no flip sides. I'll tell you what the physician fear about beta blockers. So the potency, similar efficacy, greater safety, and both predictive, PK and PD. So why? Because it's pure enantiomer and highly beta-1 selective. It becomes like nebivolol, which is gold standard. It's now metoprolol with its property, trial-proven evidence, and nebivolol kind of very highly selective and no alpha blocking action, and very, very improved safety profile. So what are the safety concerns? In my slide, when I write beta blocker, I worry कि उनको fatigue ना हो, अगर कोई athlete है या वो हो, उनका erectile dysfunction ना हो, loss of like impotence ना हो, which is a big concern. Succinate से जो racemate metoprolol से थोड़ा बहुत होता है, पर वो S करने से वो तो बात ही खत्म हो गई. So I'm resting assured, my young guy who is high risk of major adverse cardiovascular event at least wouldn't have this in his productive years, erectile dysfunction or loss of libido or something like that, or some diarrhea, constipation. Indians को अक्सर नहीं होता, or reduce interest in sex or something, tiredness. This is very important side effect of beta blocker. Or mental fatigue, depression, or extra slowness of heart rate is also a bradycardia, we call it, is also predictable when you make it racemically chirally pure by chiral switch from R to S. So S-metoprolol versus R-metoprolol. I told you that this S-metoprolol is 500 times better selective binding, cardioselective. I want only my heart or vasculature as the target, not the other things. But impure, a mix, a racemate may have both effects. And there comes the side effects. And there comes the bugbear. वहां से paranoia आता है. और ये सारी की सारी trials हैं where they found it out that how in open label, prospective, long observational, real world evidences that इतने साल हो गए हैं, and a very good thing done by, which is a world-class thing done by MCure. So in summary, we are at a high risk. Most prevalent cardiovascular disorder and hypertension is a risk factor in India. And beta blockers and initial antihypertensive makes a big sense, logical sense, even if the Westerners don't agree. And beta blockers therapy lowers heart rate, decreases myocardial oxygen demand, and do all goodies and reverse the cascade and blunt the continuum. S-metoprolol have a promising role, probably not the racemic metoprolol, to me also, and great impact on long-term prognosis in patients with heart failure, because in heart failure trials, metoprolol is the hero. And S-metoprolol is a chirally pure molecule, high cardioselectivity, definite clinical evidence, promising therapeutic choices in hypertension, heart failure. Hypertension means अभी तक मुझे और कुछ नहीं हुआ, just hypertension. Then heart failure, angina, post-CAD, MI, all this we have already told. These are a guideline direct indication, but hypertension is a controversial indication which has become now front runner for the management and deservingness. And also there's an entity in youngsters, isolated systolic, जिसे आप कभी randomly नापेंगे तो 145 by 78. So 145, 145 is not benign, and your age is just below 40. Many of you in field force are just in 20s, the kind of lifestyle, and you have normal diastolic blood pressure, but you are tachycardic, you are stress, anxiety. Month end में closing में meeting होगी, Dr. Mr. Kuldeep class लेंगे आपकी, so that's also stress. And then you have a good symptom relief with beta blocker, and you still what heart needs is a good relaxation. Heart need a good relaxation, and metoprolol succinate, or if you have S1, the best metoprolol succinate gives active relaxation. So even if you are not doing anything good to your heart in terms of amending your lifestyle, the drug is doing for you, and that's how we call it S-metoprolol as a good lusiotropic. I'm giving my heart. देखो heart जब 0.3 सेकंड में सिस्टोल करता है, 0.5 सेकंड वो डायस्टोल करता है, बहुत आराम से, बड़ा स्मूथली रिलैक्स होना चाहिए, स्टिफ नहीं होना चाहिए. उसको प्रमोट करता है in uncomplicated patients, This is a circulation paper. I just, because preparing for you, I just took it out. So positive lusiotropic effect from metoprolol succinate and also from nebivolol, I must say. So this is the beauty of these subtle things. Subtle things में मैंने intervene किया तो बड़ी बात होगी ही नहीं, sudden death होगा ही नहीं, major events होंगे नहीं. And that's where elevated heart rate rose comes, because we Indians have elevated heart rate. और वो सारा का सारा complex syndrome बनाती है. Plaque को unstable कर दे. 20% plaque rupture can kill a person, and you can't pick up a 20% plaque in routine invasive angiograms. And that's where ischemia to remodeling and then atherosclerosis as well. All this continuum can be interrupted anytime with wise choices of drug, of which the broad spectrum, selective, without side effect, S-metoprolol kind of drugs are a panacea, are a must in the spectrum to prevent heart attacks, sudden deaths, and premature life losses in India. They have to promote to the clinician who's sitting on the other side of the chair. This was my article in Times of India, how a normal looking person drops dead. And you have to de-risk CBD risk by wisely choosing and understanding the Indian genetics, epigenetics, and phenotype, and Indian kind of pharmacotherapeutic needs. Probably I try to explain in my way. And life begins with the first heartbeat and ends with the last one. So heart rate or heart capacity has been already been counted by the God. So don't waste it. And each single heartbeat is very important, and you have to regulate it through lifestyle and a wise choices of drugs for that individual. So I rest my case, but again, you have to individualize. And should there be any discussion point left, we can discuss. Thank you. I stop sharing.
Okay. Thank you, sir. Thank you so much for making it very simple and lucid. And I think beta blockers the session cannot be simpler than this. Very nicely discussed all the things, comprehensive review of all the important aspects, and especially few points which I like the most about the session. And I think these are very important key takeaways for our colleagues also, is like, sir, in the beginning only highlighted about the even though Indians don't look fat as compared to Europeans and US population, but still surprisingly hypertension onset is 10-20 years earlier.
Yes.
As you mentioned, late of 30s compared to late of 50s in Europe and US. That was a very important point. Second point, sir, highlighted was about increased sympathetic overdrive. Sympathetic overdrive we highlighted, and everybody knows that the best indicator to see whether your sympathetic overdrive is there or not is about elevated heart rate. And sir has nicely stressed on how Indians are having stressful life and elevated heart rate, and even doctors themselves sometimes are not aware that they are having elevated heart rate. Sir also highlighted the integral role of beta blocker, very intricate role of beta blocker in managing hypertension plus all comorbidities. Hypertension plus heart failure, beta blocker is essential. Hypertension plus post-MI, hypertension plus angina, hypertension plus atrial fibrillation. Everywhere there is role of beta blocker. But sir also highlighted even in uncomplicated case of hypertension, like just plain BP rise, young patients, elevated heart rate itself is one of the compelling reason to write beta blockers. And that's what sir nicely highlighted, that beta blockers in European Society of Hypertension 2023 guidelines, beta blockers again came up because it was a consensus amongst the panel, the experts task force was like, wherever there is compelling indication, you have to bring beta blockers. That was very nicely highlighted by sir. Sir also highlighted comparison between metoprolol and bisoprolol and his clinical perspective. Chirality was very nicely explained by sir, how you can make better metoprolol. Like the thing which should come to our mind, like whenever you want to choose metoprolol, go for a better form of metoprolol, and that is S-metoprolol. So very nicely summarized. And even one point sir highlighted was about preventive cardiology. Cardiology is not just about interventions and just opening the blocked coronaries and putting stents. It's about preventive cardiology, and we are very proud that our Nucron division is into preventive cardiology.
Yes.
Maybe it's beta blocker, maybe it's telmisartan, or maybe it's an ARNI in case of HF. So very nicely, like these are all important key takeaways. Even personally, I learned many things. So sir, I'll just we'll take a few questions from our the field colleagues one by one. So first question from our colleagues is like, what are some of the barriers to adopting chirally pure metoprolol in clinical practice, and how they can be addressed? Because sir, you are sitting on the other side of table.
Yeah.
Field force people come to you, and like what a doctor wants to hear, so that he's convinced and his barriers about prescribing chirally pure metoprolol are can be overcome.
Yeah, so as I told, so the fear of change, the biggest, the why are human? It's human to resist change, and if you don't change, then what is constant is change. You know that. See the play of words. So what is constant is change, and what is the biggest fear is resistance to change, or it's the biggest inertia. So things have changed. An uncomplicated hypertension in India and uncomplicated hypertension in UK and uncomplicated hypertension in Canada is different, right? And by uncomplicated means my target organ hypertension mediated organ damage, HMOD, has not happened, overt or covert. And now I am at 28. My blood pressure is 144. I told you in the last my slides, and I am competitive. I work in IT. My annual package is 35 lakh. I am just 28 and I have done this thing, and my boss says I carry on my work on weekends. I don't sleep well, and I binge eat. I go outing. I smoke occasionally. My waist circumference is 100 centimeter, and that's where I am actually generating so much of obnoxious SNS activities subtly in my system. And there, I think this metoprolol succinate works wonder to counter. So what was considered to be a risk marker, but it's now a risk factor in order to address initially into the continuum of heart disease, starting from a just minimal plaque or minimal inflammation to a florid end-stage heart. The continuum rises like a crescent-shaped half curve from both for heart and kidneys. And it acts both ways. So you are suppressing SNS and renin, you are easing out both the organs, heart and kidney. So how do I convince my physician? So if you meet a good physician, he should be a pro learn worthy. Nowadays, say, the kind of education and the kind of training are happening, these guys are not clinically so if you're not clinically trained and you're not receptive to learn new or change yourself, as I said initially during our discussion in prologue, that I am very receptive. I learn from the boys how they are trained and what they in your training sessions. You might tell me something which I don't know, and I can imbibe in my patient. I see your pamphlets and folders, what you write. Similarly, now you can make your folder or your pamphlet or your digital device, where you present that this is the flip sides, like loss of libido or erectile dysfunction, which is a bugbear. Like, it's a very paranoid thing with beta blockers. It's been inculcated so deeply. It never happened then also, but now you have made it so pure. And what was culprit in this racemate was the R effect that has been removed, and now you have a chirally very pure. It doesn't go there even, and pharmacodynamics is all beta. So you need it for your high risk patients, and you don't have to worry about. So you have to first risk assess deservingness of beta blocker. First, I know कि मेरा patient को beta blocker चाहिए. You don't need carvedilol, you don't need nebulizer for most of the patient. Don't. बच्चा BSO and this है. And then I would choose succinate because of broad spectrum usage in most of my young patient. It goes easy. So you need if your guideline directed indication, the compiling indication, as you, Dr. Rishikesh, enumerated, you need it, right? But then uncomplicated hypertension, which is a larger indication. Many of the people most of the patients that are hypertension, the root cause underpinning every other future comorbidity. So why not nip in the bud? Why not do it right away, right? So that's where I think you have to tell your HCP that this may be right choice for your uncomplicated hypertension and any other compelling indication for hypertension without having to fear about any beta. But it's as safe as any other modern generation broad spectrum beta blocker. Nebulizer is very safe. Similarly, this is also very safe, but then efficacy and trial provenness. So it's more evidence-based. Metoprolol is the most evidence-based in all such realms. And now you have S, the racemically pure. But I have to convince myself. I'm giving the exposition, so I have to convince myself, and I'm convinced. So similarly, and you can reckon the super QoS or who are we have used it, because nobody is going to trial on S and R and racemate, S-metoprolol, S-metoprolol, and racemic metoprolol, I'm doing a trial. You can't do a trial. So you can only expert opinions can be reckoned there to SCPs that this is so safe, and this works in preventing the cascading downhill course of atherosclerotic atherothrombotic continuum. So this works there also, because elevated heart rate, even 10 by 10 beats. So normally if it was to be 70 and you and me have 80 at rest, and then you have 2 or 3 other subtle risk factor which you cannot see. I'm trained to pick it up. And you are having some amalgamation and obnoxious diabolical processes happening inside in terms of inflammation, generation of oxidation or reactive species, and injuring subtly the endothelium and making it dysfunctional. And suddenly an event happens, and which could be as dreaded as sudden cardiac death. So why not intervene early, intervene smart, intervene right with the right choices? So there comes S-metoprolol, S-metoprolol over the racemic metoprolol as one of the very foundational choice. But if you have heart failure, angina, post-MI, PCI, revascularization, वो तो फिर बहुत सिंपल है, दवा तो देना ही है. पर जो अनकॉम्प्लिकेटेड है उनकी बात कर रहा हूँ.
Yes, sir. Thank you, sir, for that elaborative answer. Next question is about your clinical experience with S-metoprolol and MedPure. Like, what feedback have you received from patients when you are using chirally pure
So whatever patients
S-metoprolol
I
in your
have, they are
patient?
continuing still, and there's no side effect. And all of them are young. Huh? So when I'm in my definition, I say young, they are under 40.
Okay.
40 is a very ripe age in heart disease. Parlance nowadays in India, if I draw it likeness, 40 here is like 60 is there on the western side. So I don't lay any stone unturned and leave any stone unturned. I go all guns blazing and admit, and whosoever is on, I use again other beta blockers also as per the phenotype, and whosoever receiving this enantiomer and and the MedPure thing, and they are on that without having to stop therapy for whatever reason, right? I might have to
Yes, sir.
stop for bisoprolol, I remember, right? But then for probably very the whatever selected patient on S, I never stopped it.
Okay. And sir, this was about like selecting S-metoprolol over metoprolol. There is one more question. Like, if some doctor is already prescribing metoprolol for his patients, like
So you can
the
safely
racemic
switch.
mixture.
Yes, you can safely switch.
So if yeah. So if a patient is already on racemic metoprolol, what considerations should be taken into account by doctors when switching from chirally the racemic to chirally pure metoprolol?
Yeah, so probably somebody who is stable on the previous dose of the conventional metoprolol, the racemic metoprolol, and his blood pressure above 30, so he can be this on the same dose, no problem. So the saying going that this is 2.5 mg is like 25 mg is like 50 mg of this, and 50 mg is like 100 mg of this, could be right for a naive patient. If you're starting, he has never been exposed to beta blocker earlier. But if you're exposed to beta blocker earlier, he can be the same dose. The say 25 mg metoprolol, he can take 25 mg of S metoprolol or MedPure there. So this is good. But if he wants, he can come down to 50% of the dose, and then you can build up as per the heart rate thing, and shouldn't be going to hypotensive. It's not that only this good drug, that they must also be receiving telmisartan, say for the example, or other drugs. And then I learned that you have a good combination, very good combination. Telmisartan 20 mg with 25 mg of this. So I said that the syndrome makes us in such a way we have borderline rise of norepinephrine, borderline rise of angiotensin. Do they go hand in hand? And one begets another. This is a vicious circle. And then you don't need a robust dose of both the things on the other side of the spectrum. You just need minuscule of this and just put in without having to worry about any side effect. Gone are the days. And then actually you are primarily preventing. So this drug, in this combo, you have to promote 20 this, 25 this. And this is just minor vacillation that has happened, will settle your all blood pressure. It's not for your blood pressure. Blood pressure will also fall in place. It's for your risk. The part of which is controlling your systolic blood pressure, ambulatory blood pressure, nighttime blood pressure, office blood pressure, everything will come into place. So these borderline risk factors requires borderline dosing of this antagonizing maladaptive neurohormonal system. Antagonizing maladaptive neurohormonal system. अब ये सब आप सीखेंगे. अब मैं फील्ड फोर्स से बोल रहा हूँ. If they are around, they can communicate to, है ना, in such a way, because ये books में नहीं लिखा हुआ, and science is long chain. The research goes so ahead, and then first guideline makers take the cognizance 3-4 years after that. Then they adopt it, the research, and then the textbook takes even 3-4 more years, and then you are behind the current research and current paradigms. So हमको बताना होता है, और you can make say a very responsible company have a very responsible pamphlet or education material which becomes a reference point at times, and because it derived from your also. So that make a good reference point on your displays, and educate the SCP through your reference points, and they can quote people also, and you can quote the learner, because you cannot derive objective evidence. At best, like in India, we can do some studies or sham studies, but this is a very postulation that I am saying it will work, the lower dosing of this, and for an uncomplicated hypertensive. Complicated, no enigma, no rocket science, but uncomplicated is elusive, is ambiguous, is doubted, and that's where I should. But for last 45 minutes, I've been telling all those things and how it impacts. Yeah.
Yeah.
I'm not able to hear.
Thank you, sir, for such an elaborative answer. Yeah, sir. Can you hear me? Hello.
Yeah. Now. Yeah.
Yeah.
No,
So,
I
sir,
can't
thank
see
you
the
for
trending
the.
question.
So,
Yeah.
thank you for such an elaborative answer, sir. And what 2-3 key takeaways I can summarize from the, especially from the QA session. What sir is highlighting is like combination therapies are more and more adopted now in hypertension management. Scope of combination therapies of metoprolol or S-metoprolol are increasing. And he talked about two villains. One was angiotensin and second villain was norepinephrine. Both are addressed by telmisartan and S-metoprolol. That is an important fact. Second things are highlighted in his data also. Like he presented data of thousands of patients in India who have elevated heart rate, because in conferences also many doctors are talking nowadays that Indians have that increase heart rate more than 80 beats per minute. That is one of the hot talking point in conferences also. And one more thing, sir, as very nicely said in the beginning, like the doctors who is adopting S-metoprolol has that freedom to have that half dose, which is equally efficacious to full metoprolol. Plus, he also has an option of going to full dose also if required. Again, if the patient is already tolerating the therapy, that was nicely highlighted. And one more thing which was highlighted was what sir mentioned is a very important point for especially for our field colleagues. Like he said, sir is so knowledgeable and updated about his knowledge, but still he is always saying, I am always eager to learn from the promotional material which the field colleagues bring to him. So there is definitely scope to talk a lot of science with the doctors, and doctors are always eager to learn, and they're always very curious to have new information. This is again, I think, very important insight we have got from sir. So thank you, sir. Now I would like to invite Mr. Kuldeep Sharma, who is our business development manager, to give vote of thanks. Over to Kuldeep.
Thank you, Dr. Rishikesh. So,
and before you come in, Kuldeep, just mention the number of people who are attending the session as well.
So yeah,
sir,
the numbers with me are 493 people right now who are live.
Oh, you have a huge
listening to this
field force, huh? 493.
yes, sir.
So your entire army in MQ. Wow. Good.
Right.
Sir, it is not only India, but people from Nepal has also joined.
Nepal, I came to know of it. Yeah.
We
India
have
and Nepal
multiple
team is there, sir.
so, yeah.
Yeah.
together.
So Nepal will become now racemically pure. Yeah.
Right, sir.
Yes.
Yeah.
So it's a special occasion, sir, when we are completing 20 years of
20 years.
Medcare.
Yeah.
And on this special occasion, it is my
All
right,
the
sir.
best.
Thank you.
Thank you, sir. So it is my privilege to propose a vote of thanks, sir, to Dr. Prashant Advani, sir, on the behalf of entire MQ Nucron team. Thank you very much for sir for giving your precious time from your busy schedule to address all of us on MedPure Excel on completion of 20 years. Thank you very much, sir. Once again.
So welcome. Thank you.
Thank you, sir.
Thank you. Look after yourself well, improve lifestyle, and stay away from hospital and enjoy planet Earth with good quality of life. And
Right.
of course, we should have racemically pure things always. A racemically pure wife, right? And everything else. Perfect on a lighter note. So see you guys,
Yeah.
and look out, be hail and hearty. God bless. Bye. Good night. See
Thank
you.
you so much.
Thank you so
Thank
much,
you,
sir.
sir.
Thanks a
Good
lot.
night.
It's
Thanks a
been
lot.
a privilege hearing you today.
Same.
Thank
Like
you.
I enjoyed
Good
too.
night, sir.
Bye. Very
Thanks,
tired.
sir. Yeah.
I sign off. Thank you.
Bye
Thank
bye,
you, sir.
sir.
Thank you, sir.
Good night.
Good night, sir.
Good night.
Nirav, you can stop recording. Nirav, you're there.
I think he's not there.
No, he's here. Nirav, you have to stop recording now.